Hey folks, Scott Weingart here, and this is an EMCrit. Today, we're going to discuss the EVERDAC trial with its lead author. So let me give you a quick summary of the trial. This was a really well done trial. So randomized control, open label, pragmatic trial in which patients are randomized to either receive an arterial line catheter. All right, so over 1,000 adult ICU patients admitted within 24 hours of shock. Patients were randomized 1-to-1 to either early invasive or non-invasive first. Primary endpoint was all-cause mortality at 28 days. So the exclusion criteria. So if you could not place a brachial cuff or the brachial cuff was not displaying a blood pressure, patients on ECMO, patients on high-dose vasopressors. But you might be like, oh, wow, then they didn't really test it. Well, the doses that excluded the patients were crazy. So they had to be above 1.2 micrograms per kilogram per minute of a combination of their epidose and their norepidose. And most of that was norepi, which means the patients had to be on like 70 to 100 of norepi to get excluded. Patients with severe traumatic brain injury or patients whose BMI was greater than 40. The 28-day mortality was basically the same. It was a non-inferior study. There was a small amount of crossover. You could look at the study for that. There was safety criteria that caused the non-invasive group to cross over. And one of them, the primary one that we'll talk about in the show, is if they met that same safety threshold of those enormous doses of norepi, they finally would cross them over. I guess if they're on 110 micrograms of norepi, then they'd cross them over. There were more hematomas and bleeding from the arterial line catheters. Obviously, there was a subjective assessment that the non-invasive cuff was more annoying when it was there versus the arterial line catheter. But obviously, that excludes the pain of putting in the arterial line catheter, which I don't think they really discussed in the trial. But in essence, I would just say both groups were equivalent, meaning that whatever the arterial line was providing, if it was providing anything, it did not have patient-important outcomes measured by this trial. Yeah, I think I could leave it there, and then we'll have the discussion with the lead author, Gregor, and then I'll give you my conclusions at the end. And obviously, if you want to read the paper and find out all of the intricacies, then you could check it out in the show notes. Who are you and what do you do?
Hello, my name is Grégoire Muller. I'm a French intensive care physician.
All right. And you wrote the EVERDAC trial, which was, in my estimation, amazing. I was blown away by this paper. It's really a fantastic work. So what inspired you to do this study?
First, it was previous work from my colleague Thierry Boulin. He worked with Stéphane Herman and Karim Lacal in a non-invasive blood pressure monitoring, and to try to show that you can use non-invasive blood pressure monitoring instead of invasive blood pressure monitoring. And I think the EVERDAC trial is a masterpiece of their work.
Yeah, building on the foundations of predecessors and just taking the work forward. So what was the hypothesis going into the trial?
Yeah, I think for most of patients with shock, the concern is that the theoretical benefits of continuous invasive monitoring have never been demonstrated in randomized trials, while the harms are very real. Hematomas, bleeding, arterial line infections, more blood sampling that may contribute to anemia and increase of the need for blood transfusion. And there is a strong convenience bias toward over-monitoring or over-sampling. So our hypothesis was not that arterial catheters are harmful, but that the systematic use of arterial catheter might not bring enough benefit to offset these downsides. And that is exactly what we observed. No improvement in mortality or organ failures with early arterial catheter.
Now, this one, it's not a huge point, but it was surprising to me, and it was why I originally wrote to you. About 13% of the patients in the non-invasive group met the safety endpoint for high vasopressors, but that safety endpoint was very high, like between 70, 100 micrograms of our version of norepi, or even double that in the French version of norepi. What's going on with your patients? Those are crazy sick patients.
Yeah, it's a very good question. 2 points. First, this percentage, well, almost identical in both groups. 13 in the non-invasive strategy group, 14.3 in the invasive strategy group. These were extremely sick patients, and their high dose of vasopressors, mostly norepinephrine, reflected the severity of illness, not the method of blood pressure monitoring, and that's very important. Second, the mortality among these patients was the same in both groups. So, using a brachial cuff did not put them into dangerous over or under titration of vasopressors. This is really important. If inaccurate cuff readings were driving clinicians to over or under press, we would have seen a signal, and we didn't.
Yeah, the fact that you did have that sizable percentage, I think adds so much validity to the study, because if it was only 1% of those patients, they'd say, oh yeah, but if the pressure doses get high, we better put the art line in. But no one can say that looking at this study.
Yeah, I totally agree.
All right. So then in your actual practice now, after EVERDAC, who are you placing an arterial line in?
I try to keep it simple. I place an arterial catheter when I need to have some information the non-invasive blood pressure cannot provide. So, for example, if I need estimation of the stroke volume or precise diastolic or systolic pressure for estimation of vascular tone or excessive vasoconstriction, if I only need an accurate mean arterial pressure monitoring, I always believe the non-invasive one. At the answer. Obviously, I also put arterial catheter in case the patient has the safety criteria described in a EVERDAC trial.
Quite often in emergency critical care, at the very beginning of their resuscitation, we have patients who the non-invasive just won't read. You'll press it like 8 times. They have no cardiac output. I'll put an art line in those patients. Are you advocating that those art lines get pulled? Or is it okay at that point they stay in?
I don't have the good answer, but you have to know that we excluded this patient. One of our exclusion criteria was non-invasive cuff, fails to display blood pressure value, no inclusion. But if you take a look at the flow chart, only few patients, 84 patients among the 4,000 assessed for eligibility, only these few patients were excluded because of failure of displaying non-invasive blood pressure. Those patients probably need an arterial catheter, or they need immediate resuscitation before the cuff has any chance to work.
I love it. All right. So now I have a sizable portion of nurses that listen to the show. And so the question they want me to ask is, do you hate ICU nurses, Gregor?
No, absolutely not. I think arterial catheters are very convenient for both nurses and physicians also, but convenience is not patient-centered benefit. If you think about blood draws, note that we recommended to draw blood from the central venous line. So, EVERDAC suggests that convenience alone is not enough to justify systematic arterial line, especially considering the complications.
It didn't show superiority for the non-invasive group. If the convenience factor in a particular ICU says we really prefer arterial lines, do you think there's a harm signal beyond what's shown in the study?
I think there is a harm signal because there is more hematomas and more complication related to the arterial line. In fact, we don't have any complication of arterial line in patients. They don't have arterial line. The first thing in a patient is do not harm the patient and do not make complication in the patient. So if you put a device only for staff convenience, and the patient may have some risk, I think it is not fair.
Yeah, no, that's fair. But to a point you just made there, our infection control folks in the hospital in the United States hate central line blood draws, and your study didn't show an increased infection rate. We have previous studies showing messing with these lines does increase infection rate, and we have a comparison between hemodialysis catheters, which have a very low infection rate, and then standard central lines where nurses are accessing it constantly, the infection rates are much higher. Do you think this will inspire more central line draws, and will that be a problem?
For me, I think you better draws blood from central line instead of venous or arterial puncture. Our data suggests that, at least in this context, CVC draws did not appear to increase infection rates. But we only have few infections, and the study was not powered to detect such differences. At minimum, we can say that EVERDAC suggests that a blanket ban on CVC draws because they probably cause infections is not well established. If the alternative is repeated, painful arterial or venous punctures drawing from the CVC may be the more patient and probably the more nurse-friendly choice.
All right, that's fair. My take home from this trial really was that if a nurse calls me at 3 a.m. that the arterial catheter has fallen out, I don't have to rush up and replace it. I could say, patient will be fine, we'll reassess in the morning, which is game-changing for me. And it really does mean patients that in the past I would have certainly placed an arterial line in, I'm going to give a strong consideration to, do they really need it? What's your take home from the study? What do you want people to know?
Exactly. I totally agree with you. I think if the lines falls out at 3 a.m., you can reasonably go back to bed. Although I think you may not fall asleep quickly because you will start wondering what the patient previously has an arterial line in place. But my take-home message is that first, if you need an accurate mean blood pressure monitoring, use a non-invasive one. The cuff gives you a good mean arterial blood pressure. If you need something else like stroke volume evaluation, diastolic measurements, okay for the arterial line. But we have to stop this kind of welcome pack. Welcome in ICU, I will put you a chest tube, CVC and arterial line, and think more non-invasively.
From what you said, you really appreciate the accuracy for MAP on the non-invasive. Yeah. But the systolic and diastolic are accurate outside of extreme ranges. So if you had a patient with, say, a head bleed, where we do generally want a systolic that's accurate, I find the non-invasive still works fine in many cases. You've mentioned a few times just the MAP. What about a patient who does need a systolic number, but they're not at the extremes? They're not 220 on the non-invasive.
How do you feel? Based on previous publication, our team showed that non-invasive blood pressure monitoring has a good accuracy to detect low mean arterial blood pressure under the 65 millimeters of mercury. The brachial curve are not made to give you the good systolic. It's a good value only for the mean arterial pressure. So if you need an accurate systolic blood pressure, I think that it's only few patients. If you need it, put an arterial catheter. But when a patient comes in ICU, don't put an arterial line quickly. Give the patient some fluid, some vasopressor, some antibiotics, go to the CT scan earlier, go to the operating room, and next you can put an arterial line. But if you delayed all the therapeutics you have to give your patient because your resident is trying to put an arterial line, I think is not fair.
That's fantastic. All right, what's next on your research horizon, Gregor?
There are several directions. We have a cost-effectiveness analysis already on the way. We also will, I hope, make a carbon footprint of the two.
Wow.
Yeah.
That's so cool.
And the next about blood pressure monitoring is a trial enrolling patients in one key features are only provided by the arterial catheter. So if you need systolic measurements, if you need stroke volume evaluation, so we have to focus on subgroups of septic or shock patients to only assess the benefit or not to put an arterial catheter in this population. And I think also there is a lot of trial to evaluate other non-invasive blood pressure devices, such as finger cuff, smartwatches also. There is a lot of things to do in this way.
I love it. I can't thank you enough. And this was fantastic speaking to you, and fantastic trial.
Thanks a lot.
So, should you stop putting in arterial lines? Well, my practice pattern is a little bit different than a inpatient ICU. I often see patients who their blood pressure cuff just doesn't read. I mean, this is not like every patient, but I definitely see this frequently. And Gregor is absolutely right. By the time they get to the ICU, their blood pressure, their non-invasive cuff is reading just fine. I had a patient yesterday, came in shock state, 50/30, BP cuff did not read at all. That 50/30 came when I finally put an art line in. An hour and a half later, after antibiotics and a little bit of pressors, well, a ton of pressors that then turned into a little bit over the next 2 or 3 hours, patient's non-invasive cuff was reading just fine. And that would have been the patient who actually made it into the EVERDAC trial, not that original patient. Now, if that art line's already in, and we had a radial art line, it took us about 10 seconds to put in. If that line's already in, should you pull it? No, I do not think so. All of the risks of hematoma, bleeding come during the insertion. And if you're good at insertion, those risks really aren't there. I'd say, I don't know, maybe 10% of my patients, we actually have to put in a femoral art line. Almost all of them, we do an ultrasound-guided radial art line that goes in on the first attempt if the person doing it is skilled and not just learning still how to do ultrasound-guided needle placement. It goes in and then it's there. So should you pull those in the ICU? I don't think you should. If it stops working, don't put a new one in. It's a very different patient. Also, I don't think this is at all applicable to trauma patients who have vasoconstrictive shock. That's a different story than the patients who have vasodilatory shock, which is the vast majority of the patients in EVERDAC. Should you put these in cardiogenic shock? I wouldn't at the beginning. I want beat-to-beat measurement in those patients, and they're also a vasoconstrictive crisis. So I would still be putting them in my cardiogenic shock patients. Anytime you need a diastolic blood pressure, a systolic blood pressure, or are using the art line for other things such as PPV or other markers that come with an art line, super important. Traumatic brain injuries were actually excluded from the trial appropriately. You need an art line in those patients if they're sick. Now, they put central lines in these patients. I have pushed for a few years now to not put central lines in my critically ill patients unless they are really, really sick. We put midlines in or just do peripheral vasopressors, meaning that without an art line and without a central line, now we're back to the drudgery of blood draws by venipuncture, which I think is horrible. So if I'm not placing a central line, I think all of the risks favor. If I say I don't need a central line for anything else, but I'm putting it in because of the ease of blood draws, it would be much smarter in those patients to just put the radial art line in. Again, minimal time, minimal pain. I anesthetize my patients. If you don't, you're a monster if they're conscious. And once it's in, that becomes my site for blood draws. The midlines might draw blood at the initial, day or so, and then they stop. They stop sometimes even more quickly than that. Sometimes they don't draw when you first place them in. They flush beautifully, but they don't draw blood. So if I had a choice between a central line and no art line, or an art line and no central line, I think the safety points to just putting in the radial art line. In my hands, I don't really see a risk. Gregor mentioned the hematoma, the bleeding. I've not seen any actual injury. Yeah, of course, sometimes we miss and we have to hold pressure for a little while, but I've not had any patient with nerve injury in over a 20-year career. I've not had any patient with a radial art line infection. I think I had one patient with a femoral art line infection. So this is very safe, but it's in many patients not necessary. Now, Gregor would say that patient safety trumps convenience. And yes, if I really thought there was a strong danger signal, I would totally agree with that. I don't think that these lines are dangerous, especially the radial art lines. And so does convenience then trump the absence of harm? I think sometimes it does. I love art lines. Once I have them in my patient, everything becomes easier. But what this trial, I think, definitively tells you is you don't need art lines. In the medical critically ill patient, you don't need them. So place them if you think they're going to be helpful, not from the point of view of monitoring their vasopressors, but from the point of view of convenience for the staff. If you want to place them, you don't need to. This trial was beautifully done. Really just a work of art for a pragmatic randomized controlled trial. I commend Gregor and all of the authors. So fantastic. They certainly proved their hypothesis. In this patient population, there is no mortality benefit, nor from the secondary outcomes to placing an arterial line catheter. This has been Scott Weingart for the EMCrit podcast saying bye-bye.